Hello lovelies, and welcome to today's video. My name is Alya and I'm so glad you stopped by. Today I'm talking about cataracts again, cataract surgery. This time I'm talking about people with astigmatism who are getting cataract surgery. So this is a really interesting topic and one that is approached in several different ways by different doctors. Everyone's got their own method and their own madness that they like to use. I'm going to tell you about some of the experiences I've had with some of the doctors I work with and what we do and the kind of outcomes it gives us. So stick around to find out if this is something that applies to you. Refractive surgeons who specialise not only in cataracts but also in all kinds of different corneal surgeries will have a particular machine that measures and maps out the cornea pretty perfectly. In the kind of clinic that I work in and in the kind of clinic that majority of people will have their cataract surgery done, these types of things will be pretty extreme. So we're talking about maybe in a year's time, over the course of an entire year of surgeries, maybe 10 people will require a full map of the cornea. Because most modern machines that measure cataracts will pretty accurately map out the cornea and will even give you kind of like flags or warnings if there's something particular about, or peculiar I should say, about your patient's cornea. So it's only for those who have a very interesting flag or something particularly unusual about the mapping of their cornea, so the very front surface of their eye, and then we will send off to someone who specializes in cornea just so that we are as aware as we possibly can about their corneal shape and what it is that's giving the machine these flags, or what's heeding these warnings. Majority of people who have something interesting about their cornea will just simply have astigmatism. Now, astigmatism is given to us, or we have astigmatism as a result of the eye not being a fully flat circle like a soccer ball, but being a little bit more egg-shaped, where it's pointy at the front and a bit more smooth and round at the back. So the front part, the pointy part, is pointy because of this cornea. So having a really good map of that cornea can be really priceless in your planning for surgery when you're someone like me and doing a work like mine. A very good quality but somewhat superficial map is more than sufficient. What I found that especially when we started using our newer machine that actually shows me a map of the cornea, all it has done really is given me a bit more information on something I was already knowing about anyway. The measurement of one axis versus the other axis is all that we really use when we're planning out the power and position of the implant that we put in during cataract surgery. So what we do is we always, no matter what eye we have, whether it's a pointy eye that's got a little bit of more point in one direction than the other giving us astigmatism, or whether it's a completely boring flat standard state-of-the-art eye with no complications whatsoever, the planning is always the same. We always look at the length of the eye, we always look at the curvatures, because even if yours is normal, it'll still be individual to you and will still impact what happens during surgery and what we choose to do for you to give you the best results. We always have a look at the back of the eye to make sure that the retina is healthy so we don't get any surprises with vision post-operatively, and different depths and sizes and things like that. So think about it a little bit like when you go to the orthodontist and they put special putty in your mouth to get a mold of your entire teeth, or if you're being measured up for like a mouth guard, they need to know all the little crevices, all the little nuances about your teeth. Now, to do that for the eye, the only thing that we have at our disposal is photography, but a particular kind of photography, a very special kind of photography that, in my instance, the machine that I have, will actually show me an image of the front of the eye, so a map of the front of the eye, but just a topography map, so just a, heights and valleys, where the curve is steeper, where the curve is flatter, that type of thing. It'll give me the depth of the front part of the eye, because then it'll tell me how deeply the lens will sit. It'll tell me how thick the natural lens is. It'll tell me how wide the eye is from one side to the other, again, because of lens placement. It will tell me the size of the eye, the most important part, because that will then give me the majority of the power. And it will also give me the corneal power, so the power of that curvature at the front. Then I will choose a lens that's either completely plain, so it'll just adjust for the length of the eye, the overall power of the eye, or, and this is the most common, of course, there'll be some astigmatism, or there'll be some asymmetry to the curvature. So what I have is power from 0.68 to all the way up to about 6 diopters of curvature that I can correct, or I can recommend doctor to correct during surgery to oppose the power of the curvature. So let's say, for example, your eye is very, very pointy, from 90 degrees up and down, so from 12 o'clock to 6. In that case, we can counteract that power in the opposite plane, so going one side to the other, and give you what will end up being 0. So you'll end up not needing glasses for that particular anomaly of your anatomy. Very cool thing that we can do with optics. Now, the same thing would have been true in glasses preoperatively a lot of the time. So what one of my doctors in particular likes to do is to compare the measurements and the maps and all the different things. And we often do take several measurements on different machines so that we know that there's no human or machine error. And then we compare that to what the person's experience has been during life. So how much of that astigmatism is because of the lens that we're about to remove, how much of it was cornea, and how much of it is retina. So we make sure that we take all the bits and bobs that we have at our disposal that we can look at and compare it all. Before someone gets an astigmatic correction for this particular doctor, I end up printing out, or producing, I should say, a book of information about this patient, using different formula, using different machines of measurement, and comparing all the different ones. So each eye, more the point, gets a full-on booklet, if you like, of information about the curvature of the eye, which direction that curvature is, sizes, depths, how accurate and how true and how repeatable those measurements are, so forth and so on. Now, the reason that I came to want to tell you guys about this particular aspect of surgery is because recently, one after the other, I've had 2 patients that have required a T9. Now, T stands for toric, and toric lenses are what correct that astigmatism during surgery. A T9 is the highest power I have that we use, and that is the 6 diopters of SIL. Now, cylinder is a type of lens that will correct for that curvature in glasses. And the lens that we put inside has that same kind of concept. It's not exactly the same as glasses or contact lenses, but it does the same thing conceptually, or from an optics point of view, in that it corrects or counteracts the astigmatism in the eye, or the pointiness of the eye. So these 2 patients needed more than a T9. The other thing about cylindric correction, or astigmatism, or torics, or whatever aspect of this particular pointy eye that you'd like to highlight, the one feature of that is they often are short-sighted. The reason for that is because having a pointy eye makes it more powerful. It's the same thing if you think about a really curved bowl tends to change the shape when you look through it, or a really curved mirror, or a really curved glass. The more curvature, the more distortion of light it will produce. And that, for some reason, we won't go into the optics in this video, will give people a bit more near sight, except it's unclear because it is distorted. It might be powerful, but it's not clear, it's not sharp. But they do have these glasses for distance, and a lot of them can get away with near vision unaided, at least for some of the time. So what I've actually discovered is there's 2 kind of ways to go about it. One is to correct as much as you can, and then potentially they'll need some corneal surgery, some laser surgery to fix the rest. Or what I've been able to achieve for one particular lady, and she's so happy, and I'm so happy she's happy, is I realized that the most correction I could offer her would leave her with a little bit of short sight and a little bit of her astigmatism. I was predicting about 2 diopters, which is significant. I mean, you wouldn't be able to see in the distance comfortably with 2 diopters of astigmatism. It's not a huge anomaly like the one she presented with, so it's relatively a lot less, but it was still an anomaly, and I wasn't happy to leave her with it. So after a lot of consideration and a lot of talking to her and discussing her lifestyles and her needs and her expectations and what we could, how we could manage expectations afterwards as well, we figured out that actually leaving her with this smallish amount of astigmatism and a little bit of short sight was actually going to be hugely beneficial to her. And because surgery was incredibly uncomplicated and there wasn't much inflammation or anything like that, she actually ended up with less than I was predicting. And she's now able to read really comfortably without glasses. She can still cycle. She's an avid cyclist, and she's doing all of that with her other eye, and she's been left really, really happy. So this brings me to my monovision video that I've done, so you can definitely look that up on my channel if you're someone who's having cataract surgery or had cataract surgery. I speak a lot about each individual. I often, almost to say interview, for lack of a better word, each individual, each patient about their needs and expectations, because sometimes people don't even realize how awesome their potential outcome could be. They come to me saying, oh, I use the computer a lot. But when you start questioning them, they might also drive a lot, and you wouldn't want to put someone who drives for hours on end, for example, in a predicament where they've got this computer vision, which might be also a significant situation in their life, but you don't want to kind of focus on one thing and then take away from another. So I always find out what people are doing, how they're living their lives. If they will need glasses afterwards, what type of glasses will be best suited, and how can I adjust my outcomes to then fit those glasses, or to then make them suitable for the glasses that they are prepared to wear. How much reading vision is achievable without creating problems, all these sort of things. So I really do go into depths about people's expectations. Another example was a gentleman who is in his late 80s, but it turns out he really enjoys hunting. So he enjoys the idea of rifling targets and things like that. He did not mention that at all, even though I did the same thing for every patient. I do the same thing for every patient. I talk to everybody. He failed to mention that he uses a rifle. And being an older gentleman, I would have never assumed any sport or anything like that unless suggested. Like, I mean, often if people are golfers or tennis players, they will often tell me that they'll volunteer that information without me having to prod too hard. This gentleman did not share that for whatever reason with me first off, and it ended up, so we ended up discussing monovision with him. He loved the idea, all these things, and then it turns out that he ended up having a little bit of this monovision in the eye that he shoots with, which is it was a whole unique situation. But luckily we were able to figure out with him that the eyepiece that he looks through is adjustable. I was able to suggest that to him because all of my eyepieces that I use to look at people's eyes are adjustable to my correction, which I happen to not have any, but they are adjustable for those technicians or clinicians who do have an anomaly. And so I suggested that perhaps his eyepiece is the same, and of course it was. And everything is work-outable is my favorite way to describe it. And this is my approach with the astigmatism. I learn everything I can about not just the eye, which is extremely, extremely important, but also the patient. And then I take the best of what I have. So the most, as I mentioned, I have in correction is 6 diopters of cylinder, and the powers are also limited. It only goes from +6 to about +30 or so. After that, there's special custom lenses, and it's a whole thing. Now there are options outside of those ranges, but they're complicated, they're higher risk, and sometimes they're just not suitable for the surgery that's needed for whatever reason. So these two ladies that came through with their funny high astigmatisms were able to be corrected purely because we were able to work out what suits their lifestyle and come up with the best lens for them. Not necessarily best lens to give them a 0 or glasses-free outcome, but the best outcome for them. So once again, I guess my advice is talk to your clinician. Advocate for yourself. Let them know what your expectations are, because we as a clinician do not expect our patients to know all there is to know about outcomes, about surgery, about procedures and all the techniques through surgery either. I don't know all the techniques that the surgeon that actually does the surgery will implement. I don't need to. All I need to know, and all I do make my business very much to know, is how those different techniques affect cause and effect on the outcome to the patient, because then I can make adjustments to impact that as well. So in the case of these two high astigmatism ladies, I knew that I wasn't going to be able to fix their problem fully in the bounds of what this particular surgeon is comfortable in doing and also has good outcomes doing. I didn't want to risk doing a surgery that was unique, because the more unique the surgery, the more unpredictable the outcome's going to be. And we were able to work out with a good deep conversation. We're talking about like a good, probably spoke for over an hour if you collect all the different conversations we had on different occasions, until we were able to come to an understanding with this one particular lady more so than the other about what would work, not just for her and for her lifestyle and for what suits her eye, but also what works surgically, so from a technical point of view. And all that was, all that was needed for that to be achieved is a really great conversation. I was able to understand her, and I was able to make myself understood to her. And we've got a happy lady. We've got a really happy lady who didn't expect to be able to read after having cataracts, but does. Didn't expect to be able to comfortably cycle after having her cataracts done, but can and does. Not only that, but she had all these expectations, or rather lack of expectations, that were then modified and were, discussed and were created purely because the time was taken and care was taken. When you're going to your surgeon, speak up. Tell them about your lifestyle. Tell them about what you think is going to happen. Let them correct you. Let them offer you what they can offer. An honest surgeon, and let's hope most of them are, if they're not comfortable giving you the results that you expect, they will either curb the expectation or maybe recommend somebody else who can, or perhaps suggest to you that what you're expecting doesn't exist, because that could also be a real limitation for your particular eye. All the machines that measure for cataract surgery will take into consideration the cornea. They just have to. It's just such a big part of what we look at. A lot of surgeons, though, will not look at the back of the eye. And this is something I've come across professionally over the last 12, 13 years. A lot of them will not consider what's happening at the back of the eye. Sometimes because they can't, the cataract will sometimes just block off visibility to the back of the eye. That can absolutely happen. But I will recommend that where possible, an OCT is always conducted before surgery. It might not always give you a lot of details, but it'll at least help you flag anomalies. A good corneal scan, I could not rate it higher. When I didn't have it, I didn't appreciate it. But now that I have it, I don't know how we ever lived without it. And I know now that I can provide people with much better predictions to their outcomes than what I could ever before. So that's really amazing. And the technician needs to know that if they're not getting a good scan, or if the scan is showing something strange, there are better machines and more specific specialists out there, and it's okay to refer out, even if it's for just one little test, maybe not the whole surgery, but just one little measurement. It's okay, and it's very correct to do so. Okay, my lovelies, I hope that those of you who are about to cross the bridge of cataract surgery have got some good information from today. It's a little bit ambiguous because every eye is so incredibly individual. I highly recommend watching my monovision video as well, because that really goes into some details about that. And remember that you may not be suitable for all these things. You may not have astigmatism, or you may have something unique about your eye that I haven't touched on. So do keep that in mind. But yeah, just have that chat with maybe not even your surgeon. It might be with the technician or with the clinician or with the nurse or whoever is working with your ophthalmologist beforehand, because being informed is the most important thing, because you can't really do cataract surgery twice. You only get one go at it. And it's important when the patient speaks up. It makes our jobs a lot more predictable and enjoyable, and yeah, we like it. we like it when the patients tell us all the information. Some more eye videos. You got to subscribe. Definitely check out the catalog. There are years and years of me telling you guys about eyes, so definitely subscribe and see more videos on this channel for more everyday things and seeing what my incredibly busy, happy, full life is all about. Head over to Instagram. Lots of cute pictures, lots of events, highlights, all the things. Definitely check it out. And wherever you are around the world, my lovelies, I hope you're having an amazing time, staying safe and healthy and informed. And I can't wait to see you on the next one. Bye.